Welcome, everyone. Thank you very much for joining us this morning or this afternoon. We'll just wait a few minutes just to allow our attendees to join the room. Just for those joining at the moment, we're just going to give a few more minutes just for everyone to access the room, and then we will kick off the webinar. Great. I can see the attendee list increasing, so I think we'll get started as we have a very busy agenda today. Welcome everyone to this webinar hosted between the Lung Cancer Policy Network and the Union for International Cancer Control's Lung Cancer Collaboration. This webinar is taking place as part of London Global Cancer Week, and we'll be focusing our discussions today on turning policy into progress, how the WHO's integrated lung health resolution can drive local action on lung cancer. Just to briefly introduce myself, I'll be co-chairing today's session. My name is Helena Wilcox, and I am the programme lead for the Lung Cancer Policy Network, and I'm based in the UK. The Lung Cancer Policy Network is a global multidisciplinary alliance of experts and advocates from around the world, all with the aim of making improving survival from lung cancer a policy priority. I want to thank my co-hosts at UICC's Lung Cancer Collaboration, and also all of the speakers who've very kindly given up an hour and a half of their time today. And thank you also to all of the attendees for joining us and sparing your time as well. Just a brief piece of housekeeping, that the webinar today will be being recorded, so you'll be able to find it within the next couple of weeks on both the networks and UICC's websites, and also will be shared by our colleagues at London Global Cancer Week. If you do have any questions during our panel discussion, anything that comes to mind while our participants are sharing their opening remarks, please do make use of the Q&A box in Zoom, and we will do our very best to make sure that we share those with our panel during the discussions. Just to kind of set the scene a little bit for the webinar, I just want to reflect that this year for the lung cancer community has been a really significant year for progress in policy at the global, regional and local level. Just to highlight a few initiatives either kind of recently announced or ongoing, just want to reflect that the International Agency for Research on Cancer are currently in the process of developing their handbook on lung cancer screening. We've seen consensus statements at a global and regional level being shared and endorsed to promote policy prioritisation of lung cancer and also provide a kind of action pathway towards that countries can take as they work to address the global burden of lung cancer. Critically, we've also seen the adoption of the integrated lung health resolution by the WHO, the World Health Assembly this year, and that is going to be a core focus of today's discussions, and also the ISLC Lancet Commission on lung cancer, to name but a few. And I think it's really important that we acknowledge the years and decades of research and advocacy efforts, including by many of the speakers today and the wider lung cancer community, to drive this change and focus on lung cancer. I just wanted to briefly set the scene for who you're going to be hearing from today. So my co-chair today is Dr. Yannick Romero from the UICC's Lung Cancer Collaboration. We'll also be hearing from Andre Ilwabi from the WHO, Rasika Bombaka from Lung Connect India, Eliana Ahmad from the Ministry of Health Malaysia, Deborah Montague from Lung Cancer Europe, Professor David Baldwin from the University of Nottingham, and Caleb Egwenu from Move Against Cancer Africa. We'll also hear pre-recorded presentations from Professor Stephen Lamb and Dr. Karen Kelly as well, who are unable to join today, but very kindly have shared their thoughts with us in advance. So with that, I'm going to pass to my co-chair, Yannick Romero, who's going to set the scene a little further for today's discussions. Thank you, Yannick.
Thank you, Elena. Thanks for the kind introduction on the topic for today. Actually, I had a difficulty today to address that question, why lung health? And when I we started the discussions a few weeks, months ago about that topic, why lung health. It was difficult, but at the same time, it's really obvious to talk about lung health in terms of integrating lung cancer within lung health. We know that lung diseases, including lung cancer, COVID-19, tuberculosis, COPD, asthma, and other lower respiratory tract infections, accounted for 18 million deaths in 2021. And those conditions affect people across all the different regions. But they hit disadvantages populations and communities due to the higher exposure to shared risk between those conditions, such as tobacco use and vaping, also indoor and outdoor air pollution, and also different infections, exposure to occupational hazards, and so on. So we wanted today also to talk a bit more, and as Helena mentioned, on the lung health resolution. Why? Because the resolution calls, and Andre Bawi, my dear friend Andre Bawi, will talk a bit more on the resolution in a minute or so. But the resolution calls on the early detection, better access to care, and stronger prevention to address lung cancer and other respiratory diseases. So that integrated approach has gained really consensus among the different member states when it was adopted last May. Why? Because it enables complementary interventions across the cancer care pathway, and it will improve cost effectiveness and health system efficiency. So, but there are still gaps. For instance, policy commitments are necessary. They are not really sufficient. Why? Because implementation at the country level is weak. Recently, we analyzed national cancer control plans globally, and we found that only 12% of national cancer control plan include lung cancer screening or early detection strategies. Compared to breast and cervical cancer, this is 9 times less. These are critical indicators that global commitments are not yet translating into national plans and also budget, because we know that the name of the game is also the money. So we want to close that gap, and this is one of the core activities that we have within UICC. So this resolution arrives at a really perfect moment because there are different converging global efforts. We've heard about the ISLC Lancet Commission on lung cancer, and Caleb will discuss that also during the session today. The IARC handbook on lung cancer screening that the work has started already earlier this year and is expected to be published within the next 18 months. So what's next? What we want to obtain within the next few months is really to build those partnerships. And the session today is really a good picture of what we want to build. We work together with the Lung Cancer Policy Network, but also with UN agencies, IARC, WHO, with different organizations. I'm thinking about Luce, but also different university and researchers. We want also one of the main commitment that we want to obtain is from the Ministries of Health and also Ministries of Finance to focus on those measurable returns in investing in lung health and lung cancer. Earlier diagnosis that will save lives, but also reduces the treatment cost. This is really important for us. We know that we want to create durable and sustainable system within countries, and independent of the national context. So really building on that. We work with WHO and IARC again to develop those technical resources that will support the implementation of the lung health resolution, create indicators and integrate lung cancer, for instance, in the best buys update. But I will let that discussion to my colleagues. The next speaker will be Andre Bawi from WHO. He's the lead for cancer control. Andre, if you're ready, please, the floor is yours. Thanks a lot.
Thank you, Yannick. A very good day to you, partners and friends. Thank you, Yannick, for the introduction. You are indeed such a dear friend to us. at WHO and on a personal level as well. Thank you to the organizers, to London Global Cancer Week, and to just begin to express appreciation and congratulations to all of us, all stakeholders who helped bring this World Health Assembly resolution on integrated lung health to life. This resolution represents the very best of what public health is capable of doing. It's community-driven, it's politically courageous, and it's shaped by multi-sectoral leadership. I also want to acknowledge the leadership of governments, particularly Malaysia, including the wonderful Dr. Ahmed, who will be on the panel, and thank her for her leadership. Thank you to partners across all sectors, the Lung Cancer Policy Network and UICC. As we've heard already, the value proposition for lung cancer is clear. Lung cancer has ranked amongst the leading cause of deaths for the past 40 plus years. And for millions of people living around the world diagnosed with lung cancer, essential cancer services are not accessible, 80% of countries or more. Behind these startling statistics and behind the stigma, lung cancer and our efforts must remain centered on the real experiences of people who are affected. In this regard, I also want to pause and thank my co-panelists, Rasika and Deborah, for their leadership and courage. So again, the massive burden of lung cancer has been neglected for too long. It's against this reality that we now see the World Health Assembly resolution on integrated lung health as a collective landmark achievement after years of political leadership and sustained advocacy. And it's because of this momentum that lung cancer, including lung health, now appears in the political declaration for the UN high-level meeting on NCDs that is still in draft form. This is an important signal. Lung cancer is no longer an afterthought. It is now embedded in global NCD and health systems reform agenda. So why does this resolution matter? Because for the first time, it provides a unifying system-wide mandate to strengthen earlier detection, diagnostic pathways, and integrated care across lung conditions and exposures. For lung cancer specifically, the resolution does three important things. First, it puts lung cancer in the lung health agenda strongly and very robustly within national health policies, particularly national cancer control plans. This gives governments a political basis to update the NCCPs, as you've heard from Dr. Romero, and to explicitly include lung cancer. This is indeed a mandate. Second, it prioritizes early detection and diagnostic pathways. This is perhaps one of the biggest bottlenecks to improving survival globally. And third, it encourages integration across health policies, service delivery, and technology procurement, helping us avoid the fragmentation that has historically slowed progress. Now, if we want this resolution to translate into real change, we need to be clear-eyed about what works. Let's highlight three strategies that we see at WHO as essential. The first strategy is very clear. Focus on country impact early. Our collective success will be judged by whether we can show measurable improvements in lung cancer control within the next 2 years. We have learned from our experiences with cervical cancer, childhood cancer, and increasingly with breast cancer. When countries are able to see early, tangible results, when programs feel remote or overly technical, momentum fades. A key ingredient here is to build implementation networks, the partnerships that will translate policy into practice. We've seen how this can work. In childhood cancer, we've done this with St. Jude Children's Research Hospital, SIOP, World Child Cancer. In breast cancer, we're building these coalitions with UICC, City Cancer Challenge, TOPIGO, and others. The same approach is needed in in lung cancer. Networks that connect radiologists, pathologists, oncologists, teams, regulators, and policymakers. Strategy number 2, we have to move quickly from global guidance to country-adapted tools. Here again, we've heard from Dr. Romero about the importance of IARC leading the way with lung cancer screening handbook. This will be a major step forward. But as we all know, evidence of efficacy does not mean an intervention is implementable and can achieve scale. Countries need tools that adapt global guidance to local realities. At WHO, with thanks to UICC, the Lung Cancer Coalition, we are developing now 2 critical tools. First, country adaptation packages to translate screening guidance into national policies and service delivery models, elevating, as Dr. Romero said, lung cancer interventions into the overall prioritized best buys. Second, data systems that strengthen the tool and underpin the evidence that will drive policy. This ensures that diagnostic capacity, referral times, treatment initiations are not only monitored, but are improved from day one, and that those improvements are sustained. Again, global guidance must be paired with local adaptation because that is what will drive real impact. Finally, strategy 3, we must own the agenda within the cancer community while also aligning across related health priorities. Integration is everyone's favorite default term in global health, but we must show what it looks like in practice. Integration is in the resolution many times included in the title. Integration must happen at 3 levels as we look to implement it from the cancer community. First, in health policies. Lung cancer must be part in national cancer control plans, but it should also be part of NCD strategies, of national health strategies, and of diagnostic roadmaps. Second, integration, service delivery. Lung cancer pathways also have to be included into PHC design and approaches, radiology, pathology, innovative technologies, molecular testing systems, and others. Third, in technology procurement and regulation. Countries need access to imaging and diagnostic technologies that will let them operationalize action in a setting that's appropriate for them. And these purchases, again, should be done with a lens on integration. Integration requires discipline. We must avoid the pitfalls of creating national health strategies or integrated health plans for their own sake. Strategies should be developed when responsibilities and resources are clear. Otherwise, we risk adding complexity rather than solving it. So what can we do next? Let me close with concrete actions that I hope each of you will recall and take away to help accelerate progress. First, engage ministries of health. Please go to your government officials. Ask them to send letters of commitments to WHO, to partners, to anyone, that they are ready to implement this resolution and commit to its mandate and its outcomes. Lung cancer integration into NCCPs, national health plans, and benefit packages. Governments are asked to make these commitments. Let's approach them together and get those commitments in writing. Second, let us pivot now to build regional implementation networks. This has been said already. Capacity building and policy change are not easy. Regional networks will help us drive shared learning, strengthen professional networks, and accelerate scale up. And finally, let's measure from day one. It in fact started a few months ago. Data will drive progress. We have to measure implementation of the resolution and our impact at the country level, from referral times, imaging availability, treatment initiation, right from the start. This is how programs stay on course. This is how resolutions are implemented. So, WHA Integrated Lung Health Resolution, a major pivotal moment for our community. We now have the political platform, the visibility, the mandate that we have long sought and needed. But our success depends on what we do now, how quickly we support countries, how deeply we integrate lung cancer into the broader health agenda, and how effectively we build partnerships that turn policy into action. At WHO, we stand ready. We are with you as a community. Because if we work together, governments, civil society, clinicians, researchers, global partners, we can ensure that lung cancer is no longer detected too late, treated too insufficiently, or financed inappropriately. Together, we will save lives. Thank you again for the opportunity to join you today.
Thank you. Thank you very much, Andre. I'm ready to draft that letter. Thanks a lot. You always have good ideas. I think, well, be ready to receive also a request for that letter. Without any transition, I think that we will go to our next speaker, Rasika, who will talk about her lived experience. So, Rasika, the floor is yours, please.
Thank you, Yannick. Hi, everyone. My name is Rasika Bumbatkar. I'm a lung cancer patient from India. I was diagnosed when I was 26 years old, and today I live in Oxford, UK, where I recently completed my studies and now work as a researcher. And I also work in an NGO called Lung Connect India Foundation in India, which supports lung cancer patients. So whenever I'm given the space to talk about my journey and share my lived experience, I like to divide it into 2 phases, where phase 1 is when I was going through the disease, the symptoms, the investigations, the diagnosis, the treatment. And then the phase 2 is the phase that I'm living right now, where I talk about the challenges I faced and the challenges I face because I talk about them. So in the first phase, the challenges were clear and they came from 2 places, the healthcare system and the society. The healthcare system failed to diagnose me early. I was repeatedly referred for the wrong diagnosis because no one imagined that someone like me, young, active, 26-year-old, could possibly have lung cancer. I was never referred to counseling or social support. There were no conversations at all about fertility, sexuality, or mental health, the things that actually shaped my life, and the conversations that I very much needed simply just never happened. So the system definitely failed me in more ways than one, but the society also failed me. I carried the weight of stigma everywhere I went. People assumed I must have smoked or that I had somehow caused the disease. I felt like my life was already written off, like cancer meant the end of everything I had worked for. And that silence, that judgment made my journey 10 times harder. And then comes the phase two, the phase where I found the courage to speak. I decided to share my experience openly, hoping that someone somewhere would not go through what I did. But even here, the challenges did not disappear. Now I sort of live under a different kind of pressure, the pressure to be this perfect patient advocate, to attend every conference out there, to speak at every event, to constantly do more, to represent everyone who cannot speak for themselves. And this pressure is just getting to me now. At the very same time, I try to show up, I try to do as much as I can, but I often find that the system shuts the door. I find these spaces filled more with doctors and researchers, but not with patients. And I honestly want to pose this question to everyone in this panel today. November is this lung cancer awareness month, and I think every single day there is some event happening. Is it really practically possible for a lung cancer patient who is actively going through treatment attend every single event and contribute? And are we really expecting that out of a patient advocate? And yes, so the phase one was painfully hard, fighting the medical system, the stigma, the isolation. But the phase two, the phase that I live in now, wanting to create change, but still either not being given the platform or just finding the pressure too much to deal with, is also incredibly hard on its own way. And I want to end uh, my story by saying this: the lived experience is not something we perform, it is something we survive. And if we want real change, then give people the seat, the power, the partnership where actually change happens. We're not just the stories to showcase, but the people who can actually help change the system. And we are ready. Trust me, we are ready. We just need you to open the door. Thank you.
Thank you. Thank you, Rasika, for those words. And just to jump on what you were just saying, last week I was in Brussels for the European Cancer Summit, where we discussed a lot on patient involvement in policy shaping and cancer control plan shaping, because only 17% of cancer plan include patient in the drafting or the implementation of those plans. And I think this is where patients should also be, as you said, not only having testimonials around those sessions that we have, but also having a role around the table in shaping those policies. So thanks a lot for your wise words. You talked about stigma, and we'll go to listen to Deborah, who will address stigma for lung cancer patients. Deborah, the floor is yours. Thanks a lot.
Thank you very much indeed. And yes, Rasika, such wise words. And I hear everything you say and would echo everything that you have said as a lung cancer patient myself. So what I was asked to do today was to share some of our findings, which back up with even more evidence behind Rasika's real story, is around the association between lung cancer, mental health, and the stigma of both, actually. And as a lung cancer patient, you carry both. I'm struggling to move my slides on at the moment. Right, lovely. Okay, so basically what I want to share with you is top line results of the Lung Cancer Europe report that we did this year, which is our 10th, looking at get a better understanding really of the impact of mental health associated with lung cancer, and to start unpacking who suffers the most, why, and out of patients and also caregivers. Next slide, please. So yes, so in essence, this is the largest study that's been carried out to date globally on lung cancer and mental health. Over 200 people took part. As you can see here, over 1,700 were lung cancer sufferers themselves, but also nearly 600 caregivers, which is actually quite important when you come to look at the results. And this was across 31 European countries. So next slide, please. So we've now got the evidence behind what anybody in the field of lung cancer already suspected, but now and knew in their hearts. But now we've got some numbers behind these, and it's quite startling that, to see the numbers. 77% feared treatment failure or cancer progression, which is a reality for a lot of lung cancer patients, in terms of certainly the oncogene driven population. They live on a daily basis with the likelihood of progression, and some of the other fears, trying to live with the likelihood of side effects, and dying is real, and also sadness, in terms of missing loved ones, that's real, and the pain that you cause to your loved ones without it being your fault in any way. So you've then got that feeling, I'm sorry, I've lost the word for it, that you feel an ownership to putting that burden on your family. But caregivers also really expressed a real challenge with their mental health. Next slide, please. These are some of the other figures that came out, and some of the important data, that 90% of people actually, faced emotional challenges on a daily basis. And that can make the difference between getting up and really wanting to stay in bed all day. Work, finances, and social life. These are all areas that are impacted once you have a lung cancer diagnosis and you start to really struggle with living with that. Next slide, please. So really, in terms of one of the things that came out of the study was looking at how did people manage to get through and live well, such as Rasika, as we've already heard from. And it's really, these are some of the findings that came out of the study. And you can see here, around trying to live and maintain a normal life is important to people. Within that, there are restrictions, as Rasika has said. As a patient going through treatment, can you be expected to turn up every day? Maybe that's too much of an ask. Moving on, please. So these were to the study that really came out the top strategies for coping, and it is maintaining a healthy lifestyle, as well as trying to live a normal life, to get support from friends and family, but also to get support from healthcare professionals. And that's where some of the holes in the service are, in terms of that mental health provision. It isn't there in a lot of cases. Can we move on, please? And that's where I want to really focus now, really more on the stigma side of it, because it impacts people accessing services and raising the challenges that they have. I mean, certainly out of the report came the finding that it was the younger carers who were actually struggling the most with their mental health. And yet they're the least likely to say anything because they feel that it's not their place. They're not the actual person with the cancer. Um, there is a lot of stigma associated with lung cancer. We know that's nothing new. Certainly, the social impact is in terms of whether you raise awareness that you have lung cancer and people try and hide it. It then causes a lot of distress. There's a lot of stigma associated with mental health. So if you then have lung cancer and mental health, then you've got, is it multiplied or is it additive? I don't know. I suspect it's multiplied. The effects on and the toll on patients. So, and it does hinder access to care. We know that. We know that people hold back from asking for help, very much so. Next slide, please. So we know that it can lead to emotional isolation, which can lead itself to physical isolation, which has an even bigger impact then on increasing people's anxiety and depression, and also can lead to challenges in maintenance of going through treatment and people having, a better compliance, if you like, than um, as they should. Sorry, I'm struggling this morning with the cognitive effects of my treatment, and I'm finding the words difficult to find. It doesn't happen every day, but it unfortunately seems to be today. So, next slide, please. So, as I was saying, it's very much having, that associated with stigma is very much a barrier to seeking help and also to generally talking about it with friends, family, or even healthcare professionals. And we talk about an underutilization of services, but I think there's two things. There's one is there are a lack of mental health services available generally across the board for people to access, and then there is the stigma associated with asking for mental health support, and so we as healthcare providers and policy and healthcare and decision makers, they really need to look at what is the provision of mental health services, and not just for lung cancer, but for all cancers. But maybe focusing on lung cancer as a start because there is such a stigma associated with it, less so with some of the other cancers. Next slide, please. Strategies for reducing stigma. I think we've got a long way to go around the educational campaigns for people to understand that anyone with lungs can get lung cancer, and that is a reality. And we, even amongst healthcare professionals, I still find, as Rashika did in her experience, healthcare professionals don't think of lung cancer in younger patients. But we need to, that message needs to be driven home time and time again. Anyone with lungs can get lung cancer. That is a reality. It's a fact. Empathetic communication. Again, this comes from healthcare professionals. I think very often I talked when we launched the report for healthcare professionals, their normal greeting is, "Oh, how are things? How are you getting on?" But actually, it's a greeting. What you need to do is to say it twice, because the second time you say it is, "How are you getting on?" And that opens the door to patients sharing their mental health needs and policy changes. There needs to be a real link between mental health services and lung cancer, and that's where we will see more patients accessing it. Next slide, please. So these are the recommendations from the Lung Cancer Europe report. It's on our website. You can download it and read it for yourself. There's a lot more in it than I've gone through today, but it's around integrated psychosocial care, looking at stigma reduction initiatives, patient education improvement. That no one said to me that you were likely to experience mental health challenges now you've been diagnosed. And actually, that should be part of the diagnosis given to patients, that, you know, this is going to take a toll on your mental health. You must share with us when it's starting to affect daily life. As I say, and that will come from more empathetic communication from healthcare professionals, definitely. Next slide, please. So for some reason, my N has gone walkabout on my slide. So, but in essence, really from Lung Cancer Europe, what we would want to say is, you know, yes, we need to put more importance on the mental health of lung cancer patients. Both have stigmas attached with them, and stigma definitely reduces quality of life for patients from both aspects. And we owe it to every lung cancer patient to ensure they have the best quality of life. And there's further guidance in the Lung Cancer Europe report that we would encourage all healthcare professionals to read. So that's really a whistle-stop tour. I could talk on the subject for days, but there we are. We don't have days. But thank you very much for giving me this opportunity to at least highlight the report is there.
Thanks a lot, Deborah, for sharing your perspectives and all around the stigma and the report, also the numbers, because I think that those numbers should not be hidden anymore. And as you said, we need to raise awareness, not only among the community, lung cancer, lung health community, but beyond that. So thanks a lot. I will introduce our next speaker. We'll talk from Malaysia, Dr. Eliana, that I know well. Eliana, please, can you discuss with us and present us the work that you've done in Malaysia in terms of lung health and the roadmap? Thank you, Eliana.
All right. Thank you so much, Yannick. Yeah, my dear friend from IICC. So as mentioned earlier, we know that the resolution on promoting and prioritizing an integrated approach to lung health was adopted during the 78th World Assembly, and Malaysia had the honor to being somehow lead sponsor of this landmark resolution together with 15 other WHO member states before it was adopted during 78 WHA. And Malaysia took this initiative to lead this resolution because we strongly believe that lung health must be recognized as a global public health priority on the same level as what we have shown for other diseases like cardiovascular disease and diabetes. And Malaysia has also been working on lung diseases for a long time, including looking at the risk factors for lung health, such as tobacco control and lung cancer screening, but it's always a study or in collaboration with academia and civil society organizations. And our experience showed that two things. Well, lung diseases are not only caused by smoking, but also environmental pollutants and occupational exposures that play a critical role. And fragmented programs do not work. So we need prevention, screening, diagnosis, and treatment to be connected seamlessly from primary care to tertiary care. So that is why this resolution is not about creating a new vertical program, but it is about bringing all existing efforts together under one integrated lung health approach. So since the adoption of the resolution, we have started on the implementation. Of course, with ongoing discussion to improve the overall process. And we have come out with a comprehensive framework to strengthen activities related to prevention, screening, treatment and control of lung-related diseases through our technical working group that involves public health physician, family medicine specialists, pathologists, radiologists, respiratory physicians, oncologists, to develop an integrated management of lung health in primary care and also in tertiary care. And we focus on strengthening activities related to lung cancer, especially together on top of COPD, asthma, and tuberculosis in this early phase. And we also focus on major risk factors, including smoking, environmental exposures, and occupational exposures. And through the implementation, and through 3 settings for implementation in the primary healthcare facilities, in the private setting, with especially those with high risk industries, and as well as through outreach activities. And we have started doing lung health screening through in our health facilities through integrated lung health management in primary care that we developed, which also includes using AI-assisted chest X-ray, replacing low-dose CT scan in the primary care for lung cancer screening especially, and that would be the highlight of this initiative using AI-driven technologies. So we always emphasize that the use of this AI-assisted chest X-ray is not to replace human or the specialists or the radiologists especially, but it is to help our medical officers in the health clinics not to miss any abnormalities in the chest X-ray. And we have made the clinical flow to be as such. Every findings from the AI X-ray must be followed by intervention, especially for suspected lung cancer. And we are targeting high-risk individuals in this screening for lung cancer, on top of asthma, COPD, and tuberculosis, especially smokers and those with occupational and environmental exposures. And to date, we have screened quite a significant number of high-risk individuals using our AI X-ray. And our AI chest X-ray has reported abnormalities in all individuals because we are screening high-risk individuals with varieties of lung abnormalities, including a significant number of nodules, out of which there is also lung nodules malignancy. This is very preliminary, and in which we feel that this is the first step in strengthening our lung cancer screening in Malaysia. So it's still a work in progress, but still baby, but progressing. Thank you.
Thank you, Eliana. That's great to see that Malaysia is on top of the lung health resolution implementation. You were championing that resolution. We worked all together with WHO and other countries, and it's great to see that it's really concrete activities that you are leading in your country. Without any transition, I think that we'll have a video from Stephen Lam, who will talk about shared risk factors. So let's listen and watch that.
So good morning, I'm Stephen Lam from BC Cancer in Vancouver, Canada. I'm going to discuss the role of environmental and occupational exposures and lung cancer risk. We all know that tobacco smoking is the #1 cause of lung cancer. However, if you look at the global burden of disease, looking at the top causes of lung cancer, we can see that there are other environmental and occupational exposures that are very important in lung cancer development. So if you look at this table, although tobacco smoking is the #1 cause of lung cancer around the world, there are some countries, for example, in South Asia, Central Asia, and certain parts of Latin America, outdoor air pollution exposure is actually the #1 cause of lung cancer. And likewise, if you look at indoor air pollution from solid fuel exposure, some of the countries, many parts of Africa, and also low socioeconomic development countries also have a very high incidence of lung cancer related to exposure to indoor air pollutants. Radon has always been touted as an important cause of lung cancer, but actually it's very regional. Even if you live in a region high in radon, it depends on how your house is being constructed. It may not have a sufficient exposure to cause lung cancer. And if you look at all the other causes, they're all occupational related, and the top one is being asbestos. So if you look at the picture of the overall annual exposure to PM2.5 around the World Health Organization recommend a mean annual exposure of PM2.5 of less than 5 microgram per cubic meter. And 95% of the world population will exceed this limit. And this is shown by the one in red or orange color around the world. So although in North America, we think that we are have very low exposure to outdoor PM2.5, but with the advent of forest fires being more and more frequent, that change the whole scene as well. We now experience a high PM2.5 exposure during forest fire seasons. If you look at the burden of lung cancer related to household air pollution exposure from solid fuel, it almost reflects similar regions around the world that have high lung cancer death related to the indoor exposure to fossil fuels. And there's good biological basis for lung cancer development from exposure from PM2.5. It can initiate, select, and promote lung cancer development. And in 2013, IR classified PM2.5 as a group 1 carcinogen. And it's a positive dose-response effect. For example, the higher the PM2.5 exposure, the higher the somatic mutations that we can see. There's also an expansion of pre-existing mutant lung cancer cells through inflammation. So this is a study from UK that showed that even exposure to high levels of PM2.5 can result in development of lung cancer within a short 3 years. And promotion of lung cancer can also occur from stimulation of pathways such as the interleukin IL-18 pathway or the angiogenesis pathway that can cause progression or spread of lung cancer. So not only exposure to particulate matter can cause lung cancer, it can also worsen the survival of patients after diagnosis of lung cancer. So the study that showed that if you have early lung cancer, if you live in a low PM2.5 region, the survival on the average is 5.7 years. But if you live in a high PM2.5 exposure region, it is actually less than half. And people who have stage 1 to 3 resected lung cancer, if they're exposed to wildfire smoke within 12 months of hospital discharge, they also have a worse survival. And there's also the well-known effect of exposure on cardiac and pulmonary disease associated exposure to PM2.5. So the question, can we improve risk prediction tool to identify people who have never smoked but are sufficiently high risk to benefit from screening by looking at outdoor exposure to particulate matter? So this is a study from that we presented, our colleague Rafael Mesa presented during the last World Conference of Lung Cancer, looking at the TALENT study, where exposure to PM2.5 is shown to be associated with high incidence of lung cancer. And we all know from other studies that if it includes spirometry or other biomarkers such as blood protein or polygenic risk score, they also improve the predictiveness of lung cancer risk models. There's a simple way to measure long-term exposure to outdoor air pollutants. This is the APEX model that developed in Vancouver by Clinton Durney. It is difficult to remember where we lived 20 or 30 years ago. So we developed this kind of point of care tool to monitor how much exposure we had in the past. So if someone cannot remember the exact address where they had before, they lived in before, they can drop a pin to where they remember is the closest landmark, closest to where they live, and then we can generate the exposure data from the years they lived there before. So this is just an example about someone that lived in Delhi in the pin that I show you. You can see that the exposure level dated back to 1998 to 2023. The exposure is extremely high in India, many times above the WHO exposure level. Indoor cooking is also associated with lung cancer. If we fry oils high in polyunsaturated fat, it can actually generate carcinogens. And deep frying is worse than pan frying and also worse than stir frying. So we need to be careful about not heating oils at high temperature during cooking. Ventilation is very important. You can see if we use solid fuel and also cook or generate heating in an enclosed space, is quite different than when you have a very well ventilated area. So IR classified indoor combustion of coal as being a type 1 carcinogen, and combustion of biomass fuel is a group 2A or probable carcinogen. So you can see if we burn things like the coal and biomass, is worse than gaseous fuel, and is better with the use natural gas, and even better using electricity. So inequity in access to clean energy for cooking and heating actually slow the decline or even increase lung cancer rate in regions with low social development index. So we can see in this study, overall in the world, there's a gradual decline in the incidence of lung cancer. But in lower social development index country, we can see the decline is much slower and actually increases in women because they spend more time indoors and exposed to cooking fumes and also fumes generated from indoor heating as well. So in summary, we can see that air pollution exposure is very important for lung cancer development. I just want to echo the ASOC position statement that we should advocate for reducing fossil fuel emission and transition to clean, sustainable energy. And I've also shown some data to look at the effect of indoor cooking. We should keep the cooking oil temperature as low as practical, and we should ensure better ventilation and use of externally vented hood. And finally, I think occupational exposures is also important, especially asbestos. We need to stop mining and using asbestos. I'll stop here. Thank you.
Wow, that video was really instructive about the shared risk factors, and with a lot of emphasis on one of the risk factors that might not be well known from the overall community and population, which is air pollution and also indoor air pollution. We just talked about shared risk factors, and we'll go to the next component of lung cancer care pathway, which is early detection. I will give the floor to David Baldwin. David, please go ahead.
Thank you very much. Just going to share my slide, I think. So am I sharing now or not?
Not in presentation mode.
What about now? Is that presentation mode?
Perfect. Yeah.
Yeah, perfect. Oh, yeah, right. So thank you very much indeed for asking me to be on this webinar. It's fantastic to hear from everybody so far. I'm going to focus on early diagnosis and lung cancer. And just as a general principle, though, and particularly in relation to this declaration on lung health, it's important in most diseases to make diagnoses as early as possible, especially where there is a small window of opportunity for treatment of whatever treatment it is. And that's sort of an obvious point. And it particularly applies to lung cancer, and it particularly applies to those cancers that tend to be more aggressive. And lung cancer is one of those diseases. It's obviously best if you can detect it very early by screening, because that means that you have a curative approach. And just to point out, apart from smoking cessation, lung cancer screening is the only intervention that has been shown to substantially reduce mortality from lung cancer. And furthermore, smoking cessation in conjunction with screening activities increases smoking cessation rates. So it's a double plus there from the screening perspective. But if you do early detection, then nowadays with our better treatment for lung cancer, early detection is even more important when people are symptomatic or just pre-symptomatic, because they're more likely to benefit from the very good medications that we have now for systemic anti-cancer treatment. Even if they're diagnosed at late stage, it's important to diagnose people early. And then another point about early detection is when you start to do early detection activities, it is highly likely that you will detect more lung cancer, because we've seen in our relatively advanced systems that when you do more tests, chest x-rays, you detect more lung cancer. And when you switch off the early diagnosis pathways, as happened in the COVID pandemic lockdowns, you see a massive reduction in incidence of lung cancer, which never recovers. We saw a 30% reduction in incidence of lung cancer during the first lockdown, just showing the impact of not actually investigating symptoms. So the imperative now, particularly because of better systemic anti-cancer treatment, is to diagnose people early, both through the symptomatic route because of the better treatment, but also screening because it is known to reduce mortality. Now, I'm just going to show a couple of slides now, but just to not, before I move to screening, early detection pathways, which have already been mentioned, are extremely important and should be part of recommended policies, because this provides a standardized way of doing early detection in the symptomatic group. And I just wanted to show you, because our program in the lung cancer screening program in England is one of the ones that has moved at pace. And you can see we really started screening at pace in at the end of the beginning of 2020 with 2021 here. And you can see a massive increase in the number of cancers detected in the service. And this is what it's done to early detection rate, looking at all cancers in our national rapid cancer registration data set. As you can see, all socioeconomic groups here have had a marked rise in early detection, and that includes all of the people that aren't screened at all. So this is an amazing impact on early detection. And furthermore, the people in the most deprived group here in blue have moved from the bottom, where they sit with all of the other tumor sites, as well as lung cancer prior to the screening activity, and they have moved to the top, showing that this is a screening program that can reduce health inequalities to some extent. There's always some people that say, well, early detection rates aren't really a measure of screening efficacy, but we are now seeing from some of the longer standing pilots a reduction in stage 4 lung cancer of 25% in areas that have been screened versus those are not screened. So this is something that is working. And I'd just like to say that the interventions in areas that cannot do lung cancer screening with low dose CT is not an issue, in the sense that there is so much disease of the lungs there that will be detected as a result of interventions that are primarily designed to detect lung cancer, that the benefit is likely to be very much greater than we would anticipate from just lung cancer detection, early lung cancer detection. So this is an excellent resolution, and the early detection element is absolutely key as far as I can see. Thank you.
Thanks a lot, David. Actually, yeah, I think that the take-home message would be, let's screen as early as we can. Let's detect lung cancer as early as we can, because every patient will benefit from it. So thanks a lot. The next speaker will talk about collaboration and advocacy, because that's one of the main activities that we also have within UICC. It's building bridges between the different stakeholders and raising awareness. So I will give the floor to Caleb. Please, Caleb, can you share your experience? Thanks a lot.
Thank you very much, Yannick. My name is Caleb. I'm originally from Nigeria. Run an organization called Move Against Cancer Africa, and happy to be here. Thank you very much to UICC and WHO and the Lung Cancer Policy Network for involving me in this. So I think when it comes to discussions like this, I come to bring it back home, right? Because this is a global meeting, and great that it's including not just countries in the West, but as well low and middle income countries, especially Nigeria. So one of the areas that we are working on together with Lancet and ASRC, International Association for the Study of Lung Cancer, is something that we conceptualized and started launched this year in September at the World Cancer and World Congress on Lung Cancer, and it's the ISLAC Lancet Commission. And what this commission is, about is, bringing, people together so that we can see the advances that we've seen, happen in the, high income countries can, as in trickle down to the low middle income countries, especially, Africa. So one of the things is we've seen the lung health, resolution. I personally think is, as in something very fantastic, a great tool that we could actually use as in to get, governments in Africa and low middle income countries, involved to talk more about lung cancer. And as well, one of the issues that we've had in Africa is, and as well, other parts of the world, it's a situation where you have, misdiagnosis, right? So you have people who, come into the TB clinic and they're being treated for drug-resistant TB, and eventually, it happens to be that it's lung cancer and it's found at the late, stage. So I think, the lung health resolution, it's something that brings together all stakeholders, so that we can be able to work on this together and see. I call it like the sandwich, right? The lung health sandwich. So you have at the beginning you have and when you look at the document, you have tuberculosis, and at the end you have lung cancer, and in between you have COPD and the rest, asthma and the rest. So it's like a sandwich where you have tuberculosis angle and the lung cancer angle coming together to actually tackle this. And I believe that more people being involved with it, you have more countries and a Ministry of Health putting lung cancer as part of the cancer control plan. And that's what we are doing in our organization in ISLAC and as well UICC. And I'm great. And I want us to take this a way that when we see these things happen, we've talked about screening in the UK, these are things that we would love to see happen in Africa. So I think, collaborations like this will be able to help, move forward things and for the benefit of the patients. So I indulge everyone that is listening to, pay attention that there's a reason why this is a London Global Cancer Week, right? So it's not just London Cancer Week, right? So there's a global element part of it. So I think that's what I want to drive through. And anywhere anyone hears me talk, I try to bring this perspective whereby we'll see this, in a systematic way, not just in a linear way. Thank you very much, Yannick.
Thanks a lot, Caleb. And I really like the fact that you want to make accountable the governments in Africa and in MICs. We saw previously from Stephen also where air pollution was also, and not only in Africa, but in other countries. So it's great to hear the work that you do. I will give back the floor to Elena, my co-chair, to lead the discussion section of the session. So Elena, the floor is yours. Thanks a lot.
Thank you. Thank you very much, Yannick. Thank you very much to all of our speakers and to Stephen in his absence for his remarks as well. Very pleased to open the floor for a panel discussion. And as a reminder for those watching, listening to the webinar, you can share any questions using the Q&A box. But I have been making some notes of my own and some questions to share with everyone. Just kind of starting with Andre and the message that you shared at the beginning of we need to present data to policymakers. I think Deborah's talk and David's and many of the others as well really shared how we're collecting data that policymakers need to answer. But maybe, Andre, if I can start with you, what are some of the kind of data gaps that you that you at WHO or are coming across in conversations that you're having that the lung cancer kind of research and advocacy community can come together to help answer? And also, by extension, how can we better package the data that we do have? Because, you know, David and Stephen presented and Deborah presented a great deal of evidence that also does already exist. So how can we best harness that?
Thanks. So to start off with a great question. So governments are aware of the burden of disease in their context. So giving the usual statistics of this is the total number of cases, this is the total number of deaths, are not the type of data we need. What governments are often looking for are evidence of interventions that work in a context that's similar to their own, because that then gives them the inspiration, the reference that something can be done. And we're beginning to see that in a way, what we heard today from Malaysia and the great work that the team in Malaysia are doing, that is so powerful. So getting that out in different regional dialogues and different networks, that has a powerful downstream impact because policymakers are looking at each other. And linked to that, then we can help justify a broader business plan or investment case. This is something that we're happy to be working with UICC on, which is let's talk about lung cancer screening, but we also have to acknowledge that lung cancer screening using low-dose CT probably won't work in countries where there's 1 CT per 1 million population. They just don't have the health infrastructure to do it. It can work in a middle income country. What are the context specific factors that will help governments understand whether an intervention will work or not? And that's the type of data that's informative. So not just let's do a campaign because we know campaigns get awareness up. That's not enough of an impact. We need to know that the interventions have what are called more impact oriented measurable outcomes. The second thing that I would like to reinforce is something that Rasika and Deborah brought up, and this is a huge area of focus for us within WHO as well, which is the broader impact of a cancer diagnosis. We talk about a number, one cancer case, one person, one treatment course, and then it's over. And that is such a disservice to what actually happens to people affected by cancer. And with lung cancer, we know that it can impact the young. Rasika is a great a humble reminder to us that we need to be conscientious of this in all contexts. And of course, people in later stages in life. And with that comes a downstream impact. At WHO, just to reassure people, we are also gathering data on this. I'm suspecting we'll probably talk a bit more on the lived experience because it deserves to be a heavy topic for our focus today. But just to say, all of us are working together to tell the story of what a cancer diagnosis means. And lung cancer is a story that we don't tell enough. And when it's told, we heard so well about how the story often goes, oh, yeah, that's interesting, but you're not breast cancer, so it's not so inspiring. It's your fault. And that's really a narrative that we need to change. And those data are data we need to present in the public domain.
Thank you, Andre. I wonder if I could turn a similar question to Eliana and perhaps share from your perspective of the work that you've done on the roadmap in Malaysia on the kind of data that you've brought together, and if there's any kind of other locations or examples of kind of best evidence that you've looked to pull together the fantastic roadmap that you've developed at the Ministry of Health.
Yeah, of course, we have looked into high-income countries example and also middle-income country examples, but we and also evidence based on using AI technology in screening, especially. We have also our own local data to support using especially AI technology in this lung health initiative in Malaysia, but mostly we look back into what we had before and what we want in the future, especially for lung cancer, because we never had any specific policy related to chronic respiratory disease or even lung cancer. And given that, so we look at the opportunities as well as feasibility in having these policies, and of course I would like also to touch on how we work very well with other organizations, especially the National Cancer Society, to come up with what we want for the country, and also through the network that we have with our partners as well, and also including UICC, so we know what we want for our country, and we work as what we have within our limits and capacity and capability. So we know that although low dose CT scan is probably the gold standard, but we know we can't afford it. So what's best next that we can do for our country? So we work within our limit and we make sure that we will still be able to reach all our populations.
Thank you. And I think several, well, nearly all of the speakers touched upon kind of building capacity and this being a kind of pathway and process towards achieving a goal of earlier detection, but ultimately that must sit as part of comprehensive approaches, policy and implementation approaches on lung cancer and by extension lung health as well. I wondered, Caleb, perhaps if I could turn to you on sort of how you're kind of working through your work and in your experience of kind of leveraging infrastructure that does already exist, but also having that kind of pathway and goal towards kind of more comprehensive and very comprehensive approaches to lung cancer and lung health in policy.
Yeah, so one of the things that we are doing, so it's two-pronged. We are working or trying to work all over Africa, and as well pilots things in Nigeria. And we know that a lot of African countries already have the cancer control plan. Like Unique said, you have majorly like 3 or 4 cancers, breast, cervical, prostate, cancer as part of the cancer control plan. So one of the things that this tool we're seeing, the conversations we're trying to have within the long health resolution is to be able to talk to governments, especially governments in Nigeria, to see how can we include lung cancer as part of this policy, whereby we can be able to expand it into lung cancer. And one of the things that we've tried to do on the continental level is through International Association for the Study of Lung Cancer. We're able to bring together professionals from different countries in Africa, in Ghana, earlier this year to hold a conference, and it was the first Pan-African Lung Cancer Conference that held. And there's a commitment from ISLAC that the conference will be held every 2 years. So in 2027, early January, February, early 2027, we'll be having that same meeting in Nairobi, Kenya. So these are the more people can come together to talk about this, as in things are being shaped by dialogue, and talking together, bringing, as in hands and seeing. Like an example, I'm glad, that Andrea, from WHO is here. One of the things that helped cervical cancer at the earliest stage was when WHO endorsed the VIA and V-line test for cervical cancer, and that actually helped the awareness of cervical cancer in countries like Nigeria. So yes, it's difficult to have some low dose kystic scan in countries in Africa, but there's some leapfrog kind of screening technology that maybe can be adopted so that people can have there could be more access to lung cancer screening. So I think bringing together voices and talking about this is the way that we are pushing forward, and as well with the help of UICC to see how these conversations move forward to not just about awareness, but actionable awareness.
Thank you, Caleb. And maybe that was sort of a more kind of forward-looking question, but maybe David, from the experience of the UK of kind of reflecting back on that process from kind of earlier policy conversations and kind of gaining that commitment and traction up towards where England in particular has got to now with their screening program, and any sort of reflections that you'd share on that experience that others can learn from?
Well, I think it's about, for me, it's about having the scientific evidence to support the intervention first and foremost, because we don't want to. Well, I personally do not want to do things that will end up harming patients more than it helps them, and the evidence was slow to come, and that was an issue on its own. And as you know, in the UK in particular, they have a very tough approach to any sort of screening intervention because it is so expensive and it does have the potential for harm. But the key thing, and it's already been mentioned here, is to be engaged with the policymakers and develop a relationship which is based on trust, as opposed to trying to have an adversarial, a sort of conflicting approach to trying to win an argument. It shouldn't be in that way. Of course, it has to be like that for a start off because people don't trust you. But when they get an idea of just how reliable what you say is, they begin to trust you, and that takes time. And that's what happened with certainly with us. It was about me developing a very clear line with the policymakers, that if they came to us and they asked us a question, they would get the correct answer. They wouldn't get the answer that they necessarily wanted, but they wouldn't get anything that was unreliable. And eventually they really did understand this, that we were honest and reliable, and that's what led to them going full pelt and investing a considerable amount of money on this. Sadly, they've also made the mistake of expecting other people to be just as honest and just as reliable, and done one or two interventions, or tried to do one or two interventions which didn't have that level of evidence, and therefore, as you know, these haven't gone particularly well. Like the prostate side, for example, has not gone particularly well. It's improving now, not gone particularly well. The multi-cancer early detection test, that has also run into trouble because of the lack of scientific evidence and sound scientific evidence up front. So we do have issues. It's not all plain sailing, but the crucial thing is to be honest with what you're potentially going to achieve. And I've heard all of that today, particularly the idea of using chest x-rays, standalone chest x-rays with AI attached. Beware though, in a relatively less developed healthcare system, the amount of unknown disease there in the population is huge. We even see it in the relatively developed systems, and I can see that this is going to be incredible at detecting lots and lots of early stage cancers, late stage cancers at a time when they can be treated, but it is going to uncover, I think, a sort of unmet need, an unknown burden of disease there, which will massively improve the health of the population. I can see, unreliable smoking data, unreliable lung cancer incidence data, the two of them don't match globally. So although we have the data, it is unlikely to be correct. And as soon as you start putting in an intervention, which is a test, which diagnoses these things, you will see a change in the data as well. So that will be fascinating, and managed correctly, it could produce a huge improvement in lung health. So, but in specific answer to your question, for me, it was about building a narrative based on scientific evidence and therefore trust.
Thank you, David. And we've talked about data, and I think I have a scientific background, so to me, data immediately conjures up images of numbers, but that's not all data is. And the lived experience of people with lung cancer and with lung disease is data, and is a critical part of this story, and the advocacy and policy engagement activities that we're all seeking to do to drive change in lung cancer. And I think Deborah and Rasika, you both also shared a challenge with everyone in the room and to the wider community of how we all work together collaboratively, and how people with that lived experience are represented in those conversations. And I wondered if you hopefully have any or have one that you could share a kind of example that we can learn, that others can learn from, of how that has gone well, that collaboration, and how you and your organizations have been involved in that policy making and decision making conversation, that can provide a model and an example that we can hopefully encourage everyone to take forward, and how to engage as a collaborative approach. Deborah, did you want to go first?
I would actually state David's example, where they very clearly made use of a patient advocate with a very clear voice, and she was instrumental and part of the very strong argument that David put forward. So I think there's an example sitting there, right with us today. So that would be the one that I would state is one of the strongest ones.
Thank you, Deborah. Rasika, did you have anything that you'd like to share or add?
Yeah, sure. I think from my experience with Lung Connect India Foundation, so because this organization is all led by patients, what we did is what we came across, a lot of patients were saying that they find having that human conversation with doctors a bit difficult in a clinical setup. And because this was being raised a lot more times, we started setting up these support group meetings where doctors were involved in the meetings and the patients could just ask casual questions which they didn't get a chance to ask in the OPD. And that really worked well. And we get a lot of positive response from the patients that this is something that they find really helpful. So I think it goes back to my point of if we have patients who are actually deciding what needs to be or what is the problem and then finding a solution on it, I think it goes really well in that sense because this was all done by patients, led by patients, and this then group was created by patients where doctors are now part of it. So you see this change in the setup where the majority is not the doctors but the patients. This really created that safe space for the patients to speak and get their uh, get their problems resolved. And yeah, I think that's a great example which we can take ahead, especially where big policy decisions are made.
Thank you. And I think we also I wanted to sort of change tack a little bit, or kind of bring in another element of the conversation that we had earlier around, this resolution is on integrated lung health. So we've focused today's discussion largely on lung cancer, but of course we've also touched on many other lung diseases and conditions. But in a not dissimilar approach, Deborah, you spoke a lot about, your presentation was focused around the whole person, and not just their lungs, and lung cancer or other lung conditions, but on sort of mental health, stigma. And I think stigma has been brought up a lot by nearly all of our speakers today as a critical barrier that is very persistent and very difficult to dismantle, and we all have a role. And I thought I would sort of close the session on kind of takeaways that we can all kind of implement into our practice, into even how we talk about lung cancer, to help dismantle that stigma and take that forward as a community. Deborah, as you kindly really focus on that in your presentation, perhaps I could start with you.
For me, I think we need to, all of us, start talking about lung cancers, because it is a group of lung cancers, and I'm guilty at times of saying it and dropping the S, and we have to stop dropping the S, because the minute we do and we all start talking about lung cancers, then people won't know where that particular lung cancer came from. It will be irrelevant, and that's where we will start changing stigma. I really believe that it has to come from anyone can get lung cancer, lung cancer, and we have to make it clearer that it's a group of conditions, not one. I think that would start to help. And I've only ever seen it in one presentation that I attended, and there was an S on the cancer, and it made me smile with joy, actually. But I think we all need to do it. And I think if I look at my presentation now, I'm guilty of having dropped the S.
Thank you,
Note to
Deborah.
self today.
Yes, absolutely. Thank you. David, I can turn to you, please.
So I think there needs to be an ongoing dialogue between surrounding this whole idea of stigma, and despite what's been said, there is still a huge amount of stigma there. It astonishes me how much stigma there is there from healthcare professionals still, even now in the UK, which is and the only way to get around that is to have the dialogue and continue to send the messages and educate people, saying what we can do. I mean, our screening program, no one can ignore it in the UK now. Even the most negative person has to admit that this is quite good. And when we had the review of the NHS and it being highlighted as the one thing in the NHS which had actually showed an improvement, nothing else had improved in the NHS. And the only thing that they said was the staff were still very resilient, despite being exhausted and under-provided for, and the lung cancer screening program had produced an increase in the early stage detection rate. That was fantastic. So it stops people or ignoring it. But I've had GPs who've obviously just had a bad experience with lung cancer in the distant past and are still very negative about the whole thing. It is changing. We have to emphasize this, and extrapolating that to on a global basis, you have to start from where you can start from, which is what people are doing here, and then make the improvements, but ensure that people are brought along by the knowledge that there is room for improvement that will benefit an awful lot of people and reduce suffering, and then move from there. So I think it's about having the narrative and the dialogue, and I have to say, emphasizing the incredible importance of policy change, of having patient advocates, and the incredible importance of having them on research committees and across the board, the whole pathway, is something that I take incredibly seriously, and because I see it working. So that's what I would emphasize.
Thank you, David. Eliana, perhaps I could turn to you with the same question on dismantling stigma.
Probably in our country, I'm not really sure about stigma, but we have never talked about lung cancer before. And when we don't talk about lung cancer, 95% of our lung cancer patients are diagnosed at stage 3 and 4. And it left with only 5% with very low survival rate at 4% for stage 4. So when we have this integrated lung health approach, when we started to talk about lung health and especially lung cancer, because we have never talked about it before, people are start to take it very seriously on screening for lung health. For example, we have started also doing engagement session with high-risk industries and doing trainings, looking at the risk factors, smoking, occupational exposures. And when we talk about how now it's very easy for you to detect a nodule on an AI-assisted chest X-ray, so it really give them strong messages that, oh, this is real, and it can be detected early, and there is treatment for it. You have so much of choices for treatment if it is being detected early. So when we start to talk about it through this lung health, and we are very lucky to have our minister to support this. So it is being talk of the town, nationwide. So especially with our minister, wherever he goes, wherever platform or event that he delivers speech or keynote, he will always mention lung health, and especially lung cancer. 3 days after implementation, our minister already asking how many have we screened, how many suspected lung cancer we have detected. So we hope that we can continue that spirit, and so that we can reduce or even not to have that stigma about lung cancer in our country.
Thank you, Eliana. I think just in the noting that the time and to share Karen Kelly's remarks, I think that's a perfect note to end on, from the incredible advocacy that you at the Ministry of Health in Malaysia, working with the other WHO member states and WHO and UICC on the resolution, a perfect note to end on there. Thank you ever so much to all of our wonderful panelists. We have some final remarks from Dr. Karen Kelly, who is the co-chair of the ISLC Lancet Commission on Lung lung cancer to conclude today's webinar. I'll thank everyone now, just in case anyone does have to drop off on the half hour. But thank you ever so much to everybody, to UICC, to London Global Cancer Week, all of the panelists, and everyone that has participated online today as well. So I'll pass to Karen Kelly now.
Hi, everyone. It's Karen Kelly from the IASLC. First, let me say thank you so much for being part of today's inspiring conversation, and I apologize for not being able to join. As we wrap up, I want to reflect on the momentum we're building and the path ahead of us. This year, lung cancer was formally recognized in a World Health Assembly resolution. That recognition is not just symbolic, but it's a call to action, as you already know. It gives us a platform to integrate lung cancer into our broader healthcare strategies and to advocate for the resources and attention this disease demands on a worldwide basis. We've heard today how policy can be translated into progress, from Canada's screening initiatives to India's community-based approaches, and from Malaysia's integrated care models to the UK efforts to reduce stigma. These worldwide examples show us that change is possible when we align evidence, advocacy, and compassion. At the IASLC, we are very proud to co-lead the IASLC Lancet Commission on Lung Cancer, which was officially launched at WCLC in Barcelona this September. This landmark initiative brings together global experts from across all scientific disciplines, policymakers, and patient advocates to reimagine the future of lung cancer care, making it more equitable, innovative, and globally impactful. The Commission's goals are ambitious but necessary. We aim to reframe the global lung cancer agenda by adopting an innovative, forward-looking, and equity-driven approach, to generate evidence-based recommendations that highlight opportunities to prevent, detect, and treat lung cancer more effectively, to promote equitable, affordable access to cutting-edge therapies, diagnostics, and technologies across diverse healthcare systems, to strengthen collaboration between governments, health systems, and civil society to improve outcomes for all patients, irrespective of their geographic location or income. Lung cancer remains the leading cause of cancer death globally, with over 1.8 million lives lost each year. This is heartbreaking. Yet the burden is not shared equally. Low and middle income countries face the greatest challenges and the least access to innovation. The Commission is committed to changing that by uniting science with policy and placing patients at the heart of every conversation. As we move forward, let's remember progress is not inevitable. We have to make the progress. It requires leadership, collaboration, and a relentless pursuit focused on equity. On behalf of the IASLC, I want to thank you again for partnering here with the Lung Cancer Policy Network and the UICC, our speakers, and all of you for your commitment to this cause. Let's continue to turn policy into progress and progress into lives saved. Thank you very much.
Wonderful. So thank you again very much to UICC's Lung Cancer Collaboration, to all of our speakers today, and to our hosts at London Global Cancer Week. You can see all of our contact details for the Lung Cancer Policy Network and for UICC on the screen, and we hope that, I know that there's many familiar faces on the panel and in the audience today, but we hope that this is either the start of or indeed a continuation of all of the wonderful collaborations and conversations that we have been having over the last years, and we need to continue having in the future. So thank you very much, everyone, and with that I will conclude the webinar.